Thanks very much for letting me be here today to talk about the intersection of health and housing and a project that our plan has been involved with for the last couple of years. We started an official pilot back in the middle of 2015. And ran it for about a year, and it was a pilot that grew out of our focus on our members who are experiencing homelessness in the years leading up to that. Starting in 2012 with the carve-in of the homeless population. At that time we found we had, out of our 450,000 members, we had about 6,000 who were experiencing homelessness and living in the shelter system. We found that this population had a higher utilization than our general membership. They had almost 3 times the number of admissions. Behavioral health admissions were actually more than 9 times that of our general membership, and emergency room visits were another 3 times our general members. Goals were really to develop a mechanism to try and identify our members with the highest needs, to see if we could impact their health conditions and their Medicaid utilization, and just really to demonstrate internally to our own health plan that supportive housing could have a significant impact on people's health and Medicaid utilization. We had data, we have claims, we had the opportunity to try and figure out who some of these folks are that we could focus on. But then we really needed to collaborate with community partners, and I have to say through this project we've had a good number of really wonderful partners. So in the first year of the official pilot, like I said, ultimately really 3 members were housed who stayed on with us. And for that group, we saw an overall Medicaid savings of $160,000. Again, an underestimate because it didn't include all of the BH claims. And really most of that savings was due to a single one of those members. This was a gentleman who'd been our member since 2012. We knew him. He was actually number 4 in that original top 100 list. And in the year prior to housing, he'd had 17 admissions, 28 ER visits for a combination of alcohol dependence and depression and an array of medical conditions. So we worked with the community organization to get him into a safe haven and then ultimately into supportive housing, where he has remained. And in his first year and a half after housing, he had only 1 3-day admissions. We had one member who he actually never did use the shelter system, young man. He'd been our member since 2012, had a psychiatric diagnosis, had been living with family, attending treatment, and then he became homeless in 2015 due to the death of a family member. And not long after that, we began to see him on the hospital rosters, coming in and out. Essentially, he lived in the hospital and in the ER. And he ultimately was housed at in the summer of 2016, and he walked out of the hospital into his housing, and he's never spent another day in the hospital. In that second year, in addition to the ongoing savings from the first group, it looks like we're on track to see another similar savings, about $160,000. So we overall will probably see $320,000, $350,000 of savings. Some of the big lessons, I think there aren't shortcuts. You can't fully automate this process, and it's labor intensive to identify folks, to then find them, to engage them, and to walk them through the complicated process of getting housed. Data is necessary, and I think that's something the health plans really bring. We do bring a fair amount of data, and it's absolutely necessary, but not fully sufficient to either identify or to ultimately help somebody get into housing. Related to that, I think, is just that need to collaborate. I mean, it really meant meeting the other people who are interested in seeing this happen for folks. Bottom line, supportive housing improves health and reduces Medicaid utilization and cost.